Hello, this is another video exemplifying top-down method for learning medical concepts, this time focusing on hyperbilirubinemias. There are several ways to categorize hyperbilirubinemias. One of the best methods is to first figure out if hyperbilirubinemia is isolated or it's been associated with elevation of other liver enzymes. So, if it's isolated, it could be indirect or direct isolated hyperbilirubinemia. But if it is non-isolated hyperbilirubinemia, we have two important patterns. One is cholestatic pattern and the other is hyperbilirubinemia plus hepatocellular pattern. What is the meaning of cholestatic pattern is that not only bilirubin is elevated, total bilirubin, but we have the indicators of cholestasis, which in the lab level means alkaline phosphatase elevation is much more than or out of proportion to transaminase elevation. On the other side, if we have non-isolated hyperbilirubinemia with hepatocellular pattern, it's the opposite. It is the transaminase elevation is out of proportion to alkaline phosphatase elevation. Before moving on for the list of differential diagnosis, couple generality points here is one, we have two categories of inherited disorders under the categories of isolated hyperbilirubinemia. One is inherited direct hyperbilirubinemias, and they are Dubin, Johnson, and Rotor. And then we have inherited conditions associated with indirect isolated hyperbilirubinemia, and they are Gilbert and Crigler-Najjar syndrome. But this is not the comprehensive list, but this is the complete list for the inherited ones. The other is, when do we usually tend to use ultrasound? Whenever we have the cholestatic pattern, we tend to do ultrasound. Also, pay attention to the fact that direct hyperbilirubinemia is defined as direct bilirubin being more than 15% of total bilirubin. Now, what are the conditions or categories of predominantly unconjugated hyperbilirubinemia? Well, logically speaking, it's either we have produced a lot of bilirubin, or there is impaired uptake of bilirubin, or there is impaired conjugation of bilirubin that would result in predominantly conjugated hyperbilirubinemia. So then the next question is, what conditions can cause reduced hepatic uptake of bilirubin? That logically is seen in any condition with hepatocellular damage, such as hepatitis or cirrhosis. But here's the important point. Rifampin is a drug that reduces hepatic uptake of bilirubin, and therefore is associated with predominantly unconjugated hyperbilirubinemia. What are the conditions associated with impaired conjugation? Two conditions are famous inherited conditions of unconjugated hyperbilirubinemia, being Crigler-Najjar's type 1 and 2 plus Gilbert, and the other is physiologic jaundice of newborn. That said, we now have finally the most important category of unconjugated hyperbilirubinemia, and that is the category associated with excess bilirubin production. Always remember three major categories of excess bilirubin production: hemolysis, as well as internal bleeding and hematomas, and finally ineffective erythropoiesis. So, what are the conditions that are associated with ineffective erythropoiesis? Myelodysplastic syndrome, pernicious anemia, and vitamin B12 folate deficiency, and thalassemias. Before discussing hemolysis, can you give examples of conditions that are associated with internal bleeding causing unconjugated hyperbilirubinemia? Yes. Hematoma or GI bleeding or any massive transfusion. And finally, hemolysis. Well, you have all the differential diagnosis of hemolytic anemias. Inherited hemolytic anemias due to membranopathies, enzymopathies, and hemoglobinopathies. Examples being G6PD deficiency or pyruvate kinase deficiency, astrocytosis, elliptocytosis, or sickle cell anemia. And finally, we have acquired non-inherited hemolytic causes, including MAHAs, paroxysmal nocturnal hemoglobinuria, immune hemolytic diseases, and parasitic infection. Always remember malaria and babesia are associated with acquired hemolysis. this takes care of the unconjugated hyperbilirubinemia. Now, after the conjugation, what conditions can explain the pathogenesis of conjugated hyperbilirubinemia? When the bilirubin is conjugated, if it is not excreted by hepatocytes or there is any block to the bile flow, either intrahepatically or extrahepatically, we will have conjugated hyperbilirubinemia. Remember one general rule. Any condition that causes hepatocellular damage can cause both conjugated and unconjugated hyperbilirubinemia. So now that we are talking about hepatocellular damage by drugs and toxins and hepatitis or total parenteral nutrition, these can also be the causes of conjugated as well as unconjugated hyperbilirubinemias. But before that, remember the bilirubin conjugation pathway and its excretion requires intact canalicular membrane transporters. Do you remember what was this canalicular membrane transporter? It was our famous multi-drug resistance protein 2, or MRP2, which is responsible for the transport of bilirubin glucuronide. Do you know drugs? I know you know Dubin-Johnson and Rotor is disease associated with canalicular membrane transporter damage. But do you know drugs that can impair this transporter? This is important. That's OCPs and cyclosporin. Pay attention that we are not talking about hepatotoxic drugs. We are talking about the drugs that can impair the function of the MRP2 canalicular membrane transporter of bilirubin glucuronide, and that includes OCP and cyclosporin. But then, what are the famous drugs that are just general hepatocellular toxins? These drugs are categorized into two groups. One group is the groups that can cause hepatotoxicity in a predictable or dose-dependent fashion, and that includes the famous acetaminophen. And then we have a group that has idiosyncratic or unpredictable or not dose-dependent fashion, and that is isoniazid. And on top of that, we have some hepatotoxins, any condition that causes hepatitis, including viral and non-viral, such as autoimmune hepatitis, and finally we have TPN. Never forget the toxins associated with hepatocellular damage. It's in copper excess, like Wilson disease, kava, Jamaica, bush tea, and alcohol and vinyl chloride. All these can cause hepatocellular damage and cause the conjugated hyperbilirubinemia, but also hyperbilirubinemia of unconjugated type. Okay, the next category is conditions that impair intrahepatic bile flow. We mentioned either we have problem excreting bile or we have problem with intra or extrahepatic bile flow as underlying causes of conjugated hyperbilirubinemia. What are the conditions that can cause impairment of intrahepatic bile flow? I categorize them as 3 I's plus drugs. So inflammatory, infiltrative, infectious, plus drugs. What are the inflammatory conditions that impair intrahepatic bile flow? Well, conditions with inflammation resulting in destruction of intrahepatic bile ducts, primary biliary cirrhosis and primary sclerosing cholangitis. What are the infiltrative diseases? Well, any infiltrative disease you can think of, TB, lymphomas, amyloid disorder, can impair or destroy the intrahepatic bile. And then biliary. And then we have infections, malaria, and leptospirosis. Careful here, malaria causes destruction or impaired bile flow in intrahepatic bile ducts. Also, it causes hemolysis. So we have malaria and babesia as the causes of hemolysis, therefore causing unconjugated hyperbilirubinemia. And we have malaria and leptospirosis causing impaired intrahepatic bile flow and therefore conjugated hyperbilirubinemia. So malaria can cause both conjugated and unconjugated hyperbilirubinemia. Malaria plus babesia causes unconjugated hyperbilirubinemia because they cause hemolysis. Malaria plus leptospira causes conjugated but intrahepatic hyperbilirubinemia, and it means by impaired intrahepatic bile flow. And now here is the very important discussion of drugs. We have talked about OCPs and cyclosporin causing transporter dysfunction. We talked about isoniazid and acetaminophen causing just direct hepatocellular toxicity and impaired uptake of bilirubin. And now finally we have drugs that impair bile flow. Remember, these group of drugs are not hepatocellular toxins. These drugs just impair hepatic bile flow. So, contrary to previously mentioned drugs, especially the hepatotoxins such as acetaminophen and isoniazid, these drugs are only associated with conjugated hyperbilirubinemia. What are they? Steroids, chlorpromazine, and other antipsychotics, and erythromycin. Once more, steroids, antipsychotics, especially of phenothiazine groups such as chlorpromazine and prochlorperazine, and antibiotic erythromycin. If you want to just challenge your hippocampal region a little bit more, you can think what type of impaired intrahepatic bile flow is seen with each one of these groups. Remember, steroids, either anabolics or OCPs, sorry if it's written OCDs here, it's OCPs, they cause pure cholestatic type. You remember the elevation of alkaline phosphatase being out of proportion to transaminases, in addition to the fact that we have conjugated hyperbilirubinemia. Then we have phenothiazine antipsychotics. They cause cholestatic pattern. And then finally we have erythromycin, that it has both patterns of cholestasis and hepatitis, which is called cholestatic hepatitis. Finally, we have the easiest category, the category of conditions that impair extrahepatic bile flow causing conjugated hyperbilirubinemia. They are benign or malignant conditions. You can think of any condition that just impairs the bile flow in the bigger biliary tract branches. Either benign conditions such as cholelithiasis, post-op strictures, primary sclerosing cholangitis. So again, remember, primary biliary cirrhosis is only impairing intrahepatic bile ducts, but primary sclerosing cholangitis impairs bile flow in both intra and extrahepatic bile ducts. We have pancreatitis, we have ascariasis, we have biliary sludge disease and Mirzi syndrome. These are benign conditions. And then we have any condition with malignancies of the biliary system and pancreas, such as cholangiocarcinoma, gallbladder cancer, ampullary cancer, pancreatic cancer, or even any cancer of the liver at the region of porta hepatis, or lymph node involvement in the region of porta hepatis. So this pretty much finishes my discussion of hyperbilirubinemia. I hope you liked it. Once more, I want to emphasize that the whole purpose of this video series is just provide examples of top-down learning technique, meaning that learning could be maximized when you categorize things and when you explain them. Thank you. Wish you the best.